This patient has a history of hypertrophic cardiomyopathy and ventricular fibrillation arrest, and an ICD was implanted. Attach the telemetry electrodes. The white electrode goes on the right shoulder, the black on the left shoulder, the green on the lower right abdomen, and the red on the lower left abdomen. Have the patient lay back and place the wand over the device. The programmer will either automatically boot up or the interrogate button must be tapped. Once the interrogation is complete, the startup screen will be visible and the printout will start. This patient has a wireless device, and so the leadless ECG option is selected for viewing the rhythm. Lead 2 is also assessed. The electrograms and marker channel can be adjusted by selecting features under the Adjust button. The real-time presenting rhythm should be printed and examined. This patient's presenting rhythm is atrial pacing, as seen by the AP marker, and ventricular sensing, seen by the VS marker. The startup screen gives data regarding the generator and leads. These can also be examined on the printouts. Here the battery voltage and charge time are seen, as well as lead parameters. Percent pacing since the last interrogation is checked next. On both the programmer and printout, the number and type of arrhythmic events can be reviewed. Lead impedance and sensing trends are viewed next. The atrial lead impedance and P-wave amplitude should form relatively flat lines. An acute change suggests lead fracture or insulation breach. The right ventricular lead impedance and R-wave amplitude are viewed next. Lastly, the RV and SVC defibrillation impedances are checked. Alerts or observations can also be seen on the main screen of the programmer. Sensing is completed. For the sensing test, there must be intrinsic rhythm. If there is pacing in either chamber, the pacing rate or AV delay needs to be decreased in order to allow the intrinsic rhythm to come through. In this situation, the mode was kept as DDD and the lower rate was decreased by increments of 10 beats a minute, while maintaining an AV delay of 350 milliseconds. This test is repeated to ensure stability of the values. Threshold testing of the leads is performed next. The atrial lead is checked first. The mode is kept as DDD, though AAI can also be used if there is normal AV conduction. The rate is set about 10 beats faster than the native heart rate. The test button is pressed, and in the automatic mode, the output voltage is decreased every 3 beats. Care is taken to see where there is no longer atrial capture, seen here, as evidenced by the change in atrial electrogram. The atrial pacing threshold is the last output that successfully paces the heart before there is loss of capture. The pacing strip can also be reviewed to determine threshold. In this patient, capture was lost at 0.25 volt, and so the last setting where there was adequate capture was 0.5 volt. Next, the ventricular threshold is determined. The pacing chamber is switched to RV, and the pacing mode is changed to VVI. The pacing rate is programmed to at least 10 beats per minute greater than the patient's baseline heart rate. The ventricular lead electrogram is moved under the surface ECG on the screen, so it is easier to see loss of capture. The test button is pressed, and the output voltage decreases every 3 beats. Similar to the atrial lead, when there is no longer capture, there is a pacing stimulus but no QRS. The test can be reviewed to be sure the correct threshold has been determined. At the end of the testing, you should view the pacing settings and to ensure that the pacing output is 2 times the threshold voltage or 3 times the pulse width. The bradycardia and tachycardia settings should then be reviewed to ensure they are appropriate for the patient. Print the final report and changes this session. The telemetry electrodes are removed. The session is ended and the ICD interrogation is finished.